This next session, ladies and gentlemen, is on accelerating progress to elimination, and it will focus on innovation and adoption of new tools. We will focus on how development and deployment of new malaria tools in the APAC region is expected to help countries to achieve their elimination goal by 2030. Challenges and barriers to adoption of new tools in different contexts will be discussed with potential solutions. Our distinguished panellists will share their expertise on how countries and regions can collaborate to ensure innovations can be adopted quickly and efficiently where needed. So it's my pleasure to introduce the panel. We have Professor William Pomat, Director of the Papua New Guinea Institute of Medical Research. Professor Pomat has been the Director since 2017. At the time of his appointment, he was the head of Infection and Immunity Unit. His research is focused on respiratory disease, vaccine immunology, and particular to pneumonia, which is a major cause of death and hospitalisation in Papua New Guinea. He's coordinated field and laboratory research in pneumococcal vaccine trials to determine the best schedules for Papua New Guinea. Professor Pomat has a Bachelor of Science from the University of Papua New Guinea, a Master's of Science from UNSW in Sydney, and a PhD from the University of Western Australia. Professor Brendan Crabb, thank you, CEO of Burnett Institute, is a molecular biologist and infectious disease researcher with a special interest in malaria. He co-leads the Burnett Malaria Virulence and Drug Discovery Group. His research group develops and exploits genetic approaches to better understanding malaria parasite biology, principally to help prioritise vaccine and drug targets. Professor Helen Evans, AO, from the Nozzle Institute of Global Health, University of Melbourne, is an expert in public health and development, social policy in particular, with a focus on infectious diseases. She served as Deputy CEO at Gavi until her retirement in late 2014. Robin Davies, Director at Burnett Institute, is an Honorary Professor at the ANU, and prior to that, Head of Global Health Division and the Indo-Pac Centre for Health Security in Australia's Department of Foreign Affairs and Trade. Our moderator for this panel is Dr. Michael Charles, who is the CEO of Rollback Malaria Partnership to End Malaria. Dr. Charles is a seasoned diplomat, international development professional with over 18 years of experience providing technical, managerial and operational support to field and country officers for the Red Cross. And in his, under his tenure as CEO of RBM, they're poised to chart a resolute course towards eradicating malaria. We thank you for your time on this panel, and I will pass the over to you, the moderator. Thank you so much, Dr. Charles. Thanks.
Great. Good morning, ladies and gentlemen. It gives me great honor to be here with you. It's my first time in Papua New Guinea, and I'm loving the country already, so thank you for the warm welcome. Beautiful country, beautiful people, thank you. Today we'll be talking about innovation. I think I have one slide just to discuss some of the innovative tools that are coming up out there. But really this is a bold moment in the malaria community, in the malaria world, in our fight against malaria. Bold and happy because there hasn't been so many new tools in development that we're seeing today. Today we have not one but two vaccines. We have active ingredients, dual bed nets, and there's so much more that is coming up in the next couple of years. Such innovation that can actually lead us closer to elimination in many countries and also eradication in many countries as well. So there's a sense of hope. There's a sense of definitely we will get it right. And we're hoping that, in our lifetime we can eliminate and eradicate malaria. So these are just some of the tools that you see on the screen that will be coming in the next couple of years. I'm not going to go through them one by one, but you can obviously see that in terms of diagnostic, there's a lot of progress being made. In terms of treatment, there's a lot of progress. In terms of vector control as well. So there's a sense of hope, I think, from us in the malaria world, and thanks to the funding that has all gone into research and development and really bringing these new tools together. However, we know that the new tools alone, without adequate deployment at the right time to the right place, we know we'll still be behind in the fight. So we've been working with some of our stakeholders, and we've had a few consultations in terms of what will it actually take for all of us in terms of the big push. Commodities are there. Innovation is there. A lot is happening in the future. How can we collectively harmonize? How can we collectively make sure that there's country ownership? How can we ensure that we're generating good data? And how can we ensure that the funding is also in place to be able to roll out these new tools? We have what we call the big push. As I said earlier on, the big push is really coming together in terms of harmonization of our potential work and what it will take for us in the next 5 years. And we do actually have some colleagues here that hopefully will be engaging with yourselves from the Boston Consulting Group, engaging in terms of how do we actually deploy these tools at the right time to the various countries and communities. So this session will focus specifically on the pipeline of new tools, obviously some of the challenges, country engagement, and how can we test and adopt these new tools, as well as lessons learned as we go along. So on that note, I will turn over to my panelists, and I'll go back and sit down while we start the conversation and the discussion around the new tools, and really the excitement, and I hope you do share the excitement with me in terms of what malaria holds and what the fight for malaria holds for us in the next couple of years. Great, so thank you to my panel members for accepting to be here on stage. Thank you so much for traveling all the way that you did. But my first question will really go to Professor William. And it's basically two questions in one. The first one is, are the current tools that we have, are they working? And what can be the main advantages and challenges faced by countries in adopting new tools? Over to you, sir.
Thank you. Firstly, I want to acknowledge ministers from other countries here as well, and all of you. I think all of you have taken the time to come here to Papua New Guinea, so welcome to Port Moresby. Please, if you have time, go and see other parts of PNG and learn about the disease that we have. I also want to acknowledge this person who was always part of the malaria program for such a long time, and we unfortunately lost him a couple of weeks ago, Mr. Leo Makita, who has left us. And he is integral in ensuring that the malaria program in PNG worked really well, and in making sure that the partnership part of that worked well between implementation, research, and as well as advocacy. So he will be a big gap for us. Now, on to our topic, and I'm really privileged to be also in this panel. And coming from a research background, I guess my focus will be on the research that, on some of the work that we're doing towards ensuring that some of the tools that are available there can be looked at to ensure that it fits for purpose for Papua New Guinea and the problem that we have. Now, there's two sides to malaria program, I suppose. There's the vector side and the human side of things. And both of them, as the slides that Charles had, have all got different pipelines of innovative tools that are coming along, or have come along, or being repurposed. And so we need to look at them and integrate probably all of them. You know, from the mosquito side, I think we understand the mosquitoes. Currently, in part of our research, we are already looking at spatial eminators. Pardon me, Stefan and Tim, if I'm saying that wrong. Obviously, ITNs, or bed nets, residual spraying, and larvicide as well. So that's from the mosquito, you know, there are already tools that are available. From humans, for us to learn what the malaria is, there's RDTs that for diagnosis. There are obviously other tools as well that are available. So for us, we need to have both those side of things to be put together so that we work together. We need vector staff, or staff that are dedicated to the vector control program, and also the malaria program itself. I'll just go back to my notes so that my head is a little bit clear. And like mosquito, you know, we have different species of mosquitoes as well. We've got the parasites. We have, I think, 4 different species of parasites. So we have to be able to identify which of those parasites an individual has. At the same time, each of them has their own biology when they infect us. So we have to, with falciparum, for example, there is a vaccine, and that's a new tool for us. But Papua New Guinea also has Vivex malaria. We need to make sure that we know about Vivex as well, and that when it's hiding away in the liver, how do we diagnose it? How do we know that somebody has malaria or Vivex hiding away? So we need those tools to be available. The acceptability of those tools by the community and by us, and the previous panel talked about financing. How do we get all those money to be able to get the tools for mosquito control, vector control, plus those for us humans to utilize? And for a country like Papua New Guinea, how do we ensure that the health sector has enough financing to be able to supply all of that? Do we stratify it so that we use some of those tools first and others later on? Or how do we deal with that? We know that we might not have enough funding. And so I think trying to ensure that we are successful in implementing some of these tools, we have to go back to the communities. Initially, in the previous session, I think Mr. Rogers talked about, seeking funding, collaborating with people who have lots of money. For us, I think we need to collaborate with our communities to determine what they want, to ensure that they know what they want and they drive the agenda. We need our messaging to be the innovation that we have for our communities. So we have innovations in the tools, but we need innovation in ensuring that the information, the behavioral change information that is going out to our community is as effective as the tools that we're getting. And so the community drive the change that they want. The community is driving, each of us as individuals is also driving that need to say, this is what we want to ensure that malaria can be eliminated. And so we need that community involvement and community savvy, and our job, part of our job is to ensure that we identify innovative ways of communicating better to the community. So thank you very much.
Thank you. Thank you very much, Professor William, for taking us through some of the journey that Papua New Guinea is facing in terms of the new tools, the integration, what is working well, but also some of the challenges that you rightly highlighted in terms of accessibility, utilization of those commodities, resource optimization, financing, and as you said, really looking at innovative messaging as well as real community engagement. So that's from a country level. And it leads me to Professor Helen in terms of, from a more global level, can you talk us through some of the changing environment and lessons learned from a global health perspective in terms of the global architecture when it comes to innovation and deployment of new tools?
Thank you very much. As Michael said, I'm not a deep technical expert, so I'm going to talk from a broader perspective. And there's no doubt that the global landscape is changing massively. We had a bit of a referral to it this morning. We've got multiple crises coming, and they're all colliding with each other. So climate change, I guess, is the one that's most obvious and is so significant for malaria. But it's also unpredictable about the impact that climate change will have in what areas. There's increasing inequality, which is fueling fragmentation and alienation, which is also a problem about getting things done. There's national debt, which is also discussed this morning, which everybody's struggling with. Movement of people, misinformation and conspiracy theories. So all these colliding crises are a problem. However, I think Christoph used the term, a sense of hope. I think it's really important to have a sense of hope. We need to be positive because things can change. We can do things together. And crises can be a catalyst for change. But I think looking at my experience across the various global health organizations and institutions, but also nationally, if we want that change to be sustainable, we really need to be prepared to step outside our business as usual, our mindset, and look at how we do things differently. I was, until very recently, on the Global Fund's Independent Evaluation Committee, and one of the evaluations we did was of the role of communities, the support for community organizations, for community health workers. And one of the conclusions which really stuck with me is a statement that said, we have to look beyond risk and debt and processes to actually look at what's the impact, what's going to make a difference, and what's the counterfactual if we don't do it. And I think that's something that's really important for us all to keep in mind. We do need step changes, there's absolutely no doubt about it. We need step changes across systems, as Professor Willies said. Access to services, quality data, surveillance. We need new tools, new diagnostics. The RTDs are lacking sensitivity, new vaccines, vector control, etc. And we need capacity. It all needs to come together. It's not just tools. It's systems, tools, and capacity. So there's a shortage of trained health workers in remote areas, lack of awareness and education about malaria prevention and treatment, and a particular issue that I think is incredibly important is community participation and trust building. If we don't have communities engaged, we don't have them trusting, we're not going to make the progress we need. So yeah, we do need a step change. However, we talk a lot about innovation. Yes, we must do innovation. But it raises the question of what do we mean by innovation? We talk about innovation, we talk about catalysts for change. We need to be a bit clearer about it. At a malaria congress that Brendan and I were involved in organising in 2018, John Reeder, who some of you will know from RTD, said, innovation isn't always new things. We also need to be better and smarter about access to quality tools that we already have. So yes, we do need new ones, but we shouldn't always just be saying it needs to be new. It's about doing better with the tools we've got. We shouldn't be doing innovation for the sake of innovation, and I think that can be a bit of a challenge. And another message that's come up a lot here is that we really need to prioritise to where we can have the greatest impact, because it's a very resource-constrained environment. Let's be realistic about it. So how do we prioritise it? And that's a significant challenge for the countries in this region to scale up new tools and to then consider what are the trade-offs involved and the guidance that will help countries with trade-offs. And I think there's a role there definitely for WHO in endemic countries to determine the right mix of investments to most effectively reduce transmission and mortality. However, this sounds extremely obvious, we can't do that without resources. And speaking from the perspective of Global Fund and Gavi, they both have replenishments coming up in the next 12 months. And we heard from Jimmy Rogers about resources going down and the mix that's currently in countries. And for those resource efforts to be successful, we really need all countries to get behind them, both through countries making their own commitments, and we saw that great graph about many of the countries, really domestic commitments is great, and also being able to demonstrate that the money makes a difference. You really need to have an investment case. It's incredibly important to have the public health argument, but it also is important to have the data to show where the investment is going to make a difference and an impact generally. Treasury people aren't, in my experience in talking to them, aren't necessarily so turned on by public health data and statistics. They really want to know about what's the return on investment and what's the counterfactual if you don't do it. So I think I'll stop there. Thanks.
Great, thank you. Thank you, Professor Helen, for taking us through that in terms of, the global architecture, and you spoke about, what we call some of the perfect storm, the climate change issues, the issues around misinformation, migration, as you said, and the finances, obviously, is also playing a critical role. But obviously, community engagement and that accountability is really key. So again, moving from global to local, and then seeing, okay, who else could we potentially partner with around the new tools? Obviously, innovation does not have to be new. How do we build on existing tools? How do we make sure that we maximize the resources we have to the best of our ability? As maximizing the resources as well, we should also look around in terms of our environment and who we could continue to partner with around innovation and new tools. And that brings me to you, Professor Brennan, in terms of what do you think the role of academic institution is in the coming years in terms of supports towards elimination in this region? And what do you foresee as the main barriers and delays to new tools adoption in the region?
Well, thank you so much. And can I begin by thanking our hosts? Thank you, Minister. Thank you, Secretary. Thank you to our Applemar hosts too, to Christoph, Sartak, and all your teams. It's fantastic to be here talking about my two favourite topics, malaria, which I'm a malaria researcher, and innovation. I had an institute, the Burnett Institute, that is a research and innovation institute. And it's great to be in my hometown, which is where I did pretty much all of my schooling and spent a big part of my life. So it's fantastic to be here. I want to talk about a few principles of innovation that relate to what universities, academic institutions, research institutions like mine can play a role in. But perhaps just before that, a little bit of context that often gets overlooked, and I think is an important scene setter. When you say, why do we need to innovate? Of course, the implication is that we don't have what we need, resources-wise, resources in the fullest sense. We don't have the tools, we don't have the knowledge of how to deliver those tools, we don't have quite the funding to address an intractable problem. But you can say, we've heard it already, 45 or so countries have eliminated malaria since mid of the last century. Actually, about 60 other countries had malaria before that. So we've got 80 something countries in the world that are endemic for malaria now. 22 in this region, of course, represented by this meeting. So what's going on there? I think we often overlook the number one correlate for why we still have countries that have endemic malaria. And that number one correlate is geography. It's harder. The closer you get to the tropics, the harder it is to eliminate malaria. Makes complete sense. But I think the perception is that somehow those countries aren't doing enough, somehow those countries are at fault. The first and most important thing is it's not the case. It's simply harder. It's more difficult where there are more Anopheles mosquitoes. And so we have to innovate. What worked in other places isn't going to be simply applicable to the countries that are remaining. There's, of course, other contexts, but I think that's crucially important. It is difficult. We've seen how, of course, with climate change, malaria is going to be tougher. And it's going to be tougher the warmer it is and the more humid it is. So there is a real need to innovate. And as I've mentioned, it is in tool development, as Willie and Helen have mentioned, not just in tool development, but in delivery of those tools. And I think to answer the question I've been asked, and also relates to whoever is involved in the innovation pathway, but I think special role for institutions like ours. Some of the principles, all these principles I think have been mentioned either in the financing session or today already, and I'm just putting them in my own words. The first is that we do have to break down traditional silos, whatever the circumstance, whether they're funding silos, whether they're disease. Simon spoke about disease silos and breaking those down, dealing with 4 or 5 diseases at once, for example. It was fantastic to host Lady Ros and Marie Ange in Melbourne recently, and we were hearing about how Gavi and the Global Fund just do stuff together, lots of stuff together. This is breaking down silos. These sorts of things are very, very important about achieving more with what we've got. I think the private sector being given some of the privileges that the public sector are given, for example, on the costs of the tools that they need. If they're going to get involved in public health work, great. Let's facilitate the private sector doing that. So breaking down silos is super important. Perhaps the most important of all has also been mentioned, and that's ask the community. Ask the community what innovations they need, work with the community as you develop those innovations, and talk to the community as and after they've been rolled out. During the COVID pandemic, we worked a lot with the Doherty Institute, an institute in Melbourne, who one of their jobs was to assess how functional the rat tests were. In Australia, we had about 20 rat tests, different companies producing these point-of-care tests for COVID. And they worked wildly differently in the community. So I went to the Doherty Institute and I knew they'd tested these tests, and I said, how come they work so differently? And the deputy director told me, you know what, in our hands, all the tests work pretty similarly. 1 or 2 maybe slightly differently, but in our hands, in the lab, they all work pretty similarly. But she said in the community, they work very differently. And she said to me, that's because nobody asked the community what test would work for them. What was the simplest, easiest, most practical, whatever it was that was the barrier. She said no one had asked the community in the design of those tests or in the rollout of those tests. This is a very typical thing. Low vaccination rates in certain places usually have to do with the lack of community consultation. So embedding the community, not as an afterthought, but all along the way is crucially important. That's already come up, has come up. And the reason that's relevant to us is that's a science. That's a social science, a very undervalued social science. The science of the research that goes into tool development is appreciated. The science of tool development itself is appreciated. But the science of community engagement, much less so. Elevating that, I think, is really very important. The third is pretty obvious for my topic, that it is to embed knowledge gain. I hesitate to use the word research, but just embedding knowledge gain. I've got government officials here, and it's always asked, well, you know, what can we do to promote learnings within our own country or between countries? It's the problem. There's a lot of barriers to knowledge gain being generated in the first place. That means embedding a research culture and methodology. Again, research word is such a harsh word, but it's a rigorous approach to knowledge gain in whatever innovation is being rolled out. And to make it easy to overcome the barriers of dissemination, it should never sit in someone's drawer. One of the really fantastic programs that Burnett has been involved in the last 15 years or so in malaria is a village-based test and treat program. Many of our partners represented in the room were here. This is to say, well, can you have a village health volunteer actually diagnose malaria in the village, treat people who have a fever with malaria, and just as importantly, those who don't have malaria, make sure they get to a health facility for their pneumonia or whatever else they had. Fantastic program, and from all accounts worked brilliantly, got rolled out in several provinces. But that knowledge has never really been disseminated. There wasn't accompanying research with it. If it was to be done again, the learnings from that are nowhere near as strong as they would have been had, for example, the PNG IMR walked alongside and done the high-quality knowledge gain work. Knowledge gain is not an optional extra. It needs to be embedded so that there's learning. Everything's improved, more effective and more efficient as a result of it. And the third is related to that, and that's to be targeted. Just today, a publication came out from the Burnett and many colleagues on fine mapping malaria. Actually, a fascinating topic that looks for the antibodies to mosquito antigens in the blood of people. So if you do this was a study done in Myanmar, but it can be done anywhere. I didn't even know you could detect antibodies until I was told this story about 6 months ago. You can detect antibodies to specific mosquitoes in people, and of course you can detect malaria antibodies in people. And if you put those two things together, you can generate fine maps in countries of where the biggest problem is, and you can gradate it. So it's not just national, it's subnational, not just national, but regional, not just regional, but even sub-regional, even places in a village that are more likely to have lots more malaria than others. This sort of innovation, to be able to laser target as opposed to blanket, is amazingly powerful at being able to do more than less. So in all of those issues, what a university or a research institute or innovation house like we bring is that capacity to generate knowledge in a way that gets to everybody. By no means the ones who should do the implementation and be the only players, but embedding academic agencies like ours to fulfil those principles is crucial.
Thank you. Thank you so much, Professor Brendan, for that in terms of, the science and the need for academic institutions, research institutions, and for also reminding us the cards we were dealt in terms of the location, in terms of the tropics, in terms of just the way, the mosquito grows and is a menace in our societies. Thanks again for reminding us about, the communities. And I think from the three speakers, you've all spoken about communities and the need to continue to focus on them and work with them in terms of making sure that we collectively defeat malaria. This brings me to our other colleague, Mr. Davis, in terms of, yes, we do have the tools, but we know that there are regulatory challenges. Can you just talk through that in terms of the challenges, the regulatory challenges around development and deployment of new tools?
Thank you very much. Yeah, thanks very much. Actually, first, I'd just like to echo Willie's recognition for the huge contribution of Leo Makita to malaria control here over what was around 40 years, I think. And I know Leo was coming up to retirement shortly after this event, so this is a fitting honour for him, I think. Now, I wanted to speak really from the perspective, I'm not a regulator by any means, I want to speak from the perspective of somebody who used to manage development assistance programs which supported product development partnerships, like the Medicines for Malaria Venture, the Innovative Vector Control Consortium, and also regulatory strengthening, especially through partnerships between Australia's regulatory agency, the Therapeutic Goods Administration, and its counterparts across this region. Now, I went through 2 funding cycles, essentially, where we supported these kind of organisations, one in 2018 and one again in 2023. And I want to describe to you briefly a sort of thought process and a learning process that we went through. And in retrospect, it's, you know, I feel a bit stupid about some of the assumptions we made in 2018. But, so at that time, we were coming up to allocate resources to a group of PDPs, Product Development Partnerships, for a 5-year period. And it seemed eminently sensible to us that we should also support regional regulatory strengthening hand in hand with that support for PDPs. So we entered into a partnership with our Therapeutic Goods Administration, which was product oriented essentially. We had the idea that if our TGA were to register products, particularly including malaria control products, that were to be used in the region, then regulatory agencies across the region would have the option of relying on that market authorisation for their own purposes, or else inviting the TGA to work closely with them in assessing dossiers. And you know, we thought this would all speed up product registration for innovative products for malaria, but also for tuberculosis and a range of other things. Seemed vaguely plausible, but it didn't work out that way at all for reasons I'm sure you can all imagine. For one thing, it's not the job of a regulatory agency to be excited about innovative products. It's almost the reverse. At least they should be neutral. We as financiers and PDPs as developers are pretty excited about the new products in their pipeline, but a regulatory agency really has to establish a firewall between itself and those of us who are excited, and take a very careful look at these things. So already from the start, that sort of works against the idea that partnerships between regulatory agencies should be product oriented. And for other reasons, we quickly learned that the regulatory agencies in the region, presented with an opportunity to engage with Australia's agency, they had a whole lot of more basic concerns, a whole lot of things they wanted help with that were much more about corporate management processes, leadership, a whole range of things that were about the functioning of the agency in general, were not product oriented. Then of course there are a whole range of access issues that even if you've got market authorisation in place, there's a whole lot of other issues that need to be addressed beyond regulation. Brendan talked about community engagement, user acceptability, affordability, revision of treatment guidelines, all sorts of things. So our thought that adding the regulatory piece to the product development piece was an incomplete thought, and the implementation of it was too product oriented. So I guess that's what we learned through that first round, and we made some changes as we went along to the way to what we expected of our own therapeutic goods administration. And then in the second round of funding just last year, which saw many of those PDP funding agreements renewed, we've moved toward a model where regulatory support is much more oriented towards broad-based capacity building and partnerships between national medicines regulatory authorities across the region, and not built around specific products. And secondly, we've moved to a model where, rather than expecting regulatory agencies to be excited about innovative new tools, we would support regular collective engagements between regulatory agencies, PDPs, health ministries, a range of other organisations that provide technical support, such as Papua and APMEN and various global partners, and also academic and research institutions, so that everyone is aware of what is happening, what's coming down the portfolio, what some of the issues and priorities are. And regulators are much more comfortable engaging in that sort of portfolio-based way with that group of stakeholders than they are on individual products. And finally, the assistance that we're providing for PDPs and regulatory strengthening now, Australia, is more fully embedded in that whole ecosystem. It's backed up by support for to deal with some of the other factors impeding access that I mentioned. So that's sort of a process we went through over 6 or 7 years, and I just wanted to describe that. Regulation remains absolutely key at the national level and indeed at the global level, but supporting this area really needs to be integrated across disease priorities and products, and also integrated with respect to those barriers to access. And just the last thing I wanted to say, I mentioned the involvement of academic and research institutions in those collective engagements on regulation and product development. I'm now associated with such an institution, but that's not the reason I'm saying this. I think in environments where there is very limited capacity for post-market surveillance, it's really important that a lot of the work that's done by academics is taken very seriously and engaged with in a collaborative way by the global institutions that are setting norms and standards. We will hear a bit more about that tomorrow in relation to vector control products, but I think the academic community is to some extent an untapped resource in the area of post-market surveillance. I'll leave it at that.
Great, thanks very much, Robin, for taking us through some of the regulatory challenges and the shifts over the last couple of years. I don't want to make this just us talking. I really want it to be a dialogue. I have another set of questions, but I'm not going to ask it for now. I want questions to come from yourselves so that we can engage and be more interactive in terms of our conversation. So, do you have any questions to any of the panelists? I see Simon has his hand up. So, Simon, over to you.
Thanks so much, Michael. I just wanted to go to William. Really fascinating, William, thinking about the knowledge of the vector and the parasite and the humans. Do you have a sense, and do you have any data of, for example, mednet usage in PNG? So we talk about the tools, we get the tools. What is your sense of uptake and use, and what are your experience of community engagement and discussion about use of mednet in PNG? Thank you.
So maybe before you answer, we can just take 2-3 more questions. Yes, sir.
Yeah, I'm from Cambodia. I'm Dr. Steve from the national program. I just want to know the perspective from the global initiative or in terms of the new tool. That you have integration idea in mind, in the concept. Because usually there is a specific focus on malaria, but not other diseases, while some tool can be integrated to do so. But some problem is the innovation has been done in terms of perspective of the donor demand. Some donor may say that I'm not focused on that disease, while you use my initiative money to invest for others. But in terms of sustainability and country integration approach, how about the perspective of the global level in terms of that? That's the first question. And the second question, talking about the coordination. University has been do some research for some new innovation and so on. The universities or research has been collaborating with other universities in order to speed up, not overlap, to do all together. Why share some idea beforehand before we can push up, we can speed up the new tool that has been meet the demand of our community. Yes, that's it. 2 questions. Thank you.
Great, thank you very much. One more question? Yes, on the same table, I think.
Professor Brendan Crabb, you mentioned the value of the community malaria volunteers in reducing malaria. It's just, I've seen it, it's just fantastic. But what effect do you think this will have on the relationship between the immunity in the community? Will reduce malaria. I mean, where this program is working, the hospitals say we don't see any more severe malaria because the treatment catches it at an early stage because of the availability of diagnosis and treatment at your doorstep, as it were. And then if we prevent all this malaria, will we end up converting these places into non-immune communities so that we now have a different situation altogether with regards immunity in previously holoendemic areas?
Great set of questions. The first one was about bed net usage in Papua New Guinea. The second one was around, integration, donor demands. How can we, use the same tools, for a series of diseases, coordination between universities, and then the last one around immunity, non-immunity. If we're so successful, how do we keep the immunity going in terms of, the fight against malaria? So I'll hand over to you, William.
Thank you, Simon. That's a brilliant question, and I was going to bounce it back to that person behind you, Tim Freeman, who will have some some of that coverage information. But at the moment, I think it depends on where you go. If RAM has been there with their nets, and it's going between, I think, 14% in some areas to probably high, up to 90%. And also depends on which provinces you are going to. So the Highlands provinces, you won't see that many. I mean, we know that those provinces like Simbu, which had an outbreak recently, the usage might go up. But in each of the different provinces, there's different coverage of bed nets. And so that is something that I think we also, as part of this BCC or behavioral change communication, we need to talk to people about usage of bed nets. In some provinces, they find it hot to sleep under bed nets, and so that could be a reason why they're not using it. In some places, in some of the work that we've done at the Institute, we know that mosquitoes also change their behavior to get around the use of nets early in the evening, so that they're biting either earlier when people are still around the fire, or later when they're going to do businesses in the toilets. Or last night, for example, mosquitoes would have had a feast because everybody would have been watching the State of Origin, and so everybody would be around television somewhere. So, so net use, I think, in each of the different provinces, we need to probably advocate with the provincial malaria people and provide better messaging so that they use the nets that are there. And we also need those nets to be to last long. We know that from some of the data that we've gathered so far, that nets are not lasting as long as they used to. And so we need to identify some of those mechanisms, continue to make sure that the nets are working well over periods of time, and that they are not being used for fishing or to make sure that the gardens are, pests away from their gardens and so on. So, yep, there's all sorts of things that we need to think about when the usage of nets come up. I hope that answers your question, but we do have a couple of reports that hopefully will come out soon that will have some of those data in them for us to have a look at. Thank you.
Is this working? Yes, that's working. Seems to be a bit of jinx amongst the microphones. Thank you for your question. First of all, I just want to make an overarching comment, which I was going to make earlier, and I thought one of the other speakers might make it too, and that is that in terms of integration, vaccines aren't a magic bullet. It's great we have these vaccines, as Dr. Tedros said, but they're only for falciparum and they're only for children. So we learned in COVID that there was a bit of a danger that everybody saw vaccines as being the solution. It needs the full suite. So that's not specifically to your question, but it was a point I did want to make. I think it's a very valid question you ask. For the global organisations, it has to fit with your country systems. And I know that we haven't always been as good as we should have been in doing that. Certainly the intention's been there right from the beginning, and the rhetoric for both Global Fund and Gavi. But it's been a challenge because those two organisations are both donors, but they're also recipients, and the donors call a lot of the shots for that. And it's balancing that. So I'm not trying to defend it. I'm saying that we just all need to work on doing it better. As I said earlier, I had that quote from an evaluation study we did, which said that risk and processes often overtake it, and that acts as a barrier for the big organisations actually really funding and providing in a way that fits each of the countries, and that, you know, that will be different. I think it is, I hope it's changing. I think it's changing, but I think it has to change, because if you're really looking at impact, that's how you're going to get the impact. It's going to be working with the country systems and supporting you, and you know what works best for your country. So, yeah, I think I describe it as a work in progress, and we all just need to keep working on it.
Great, thank you. Professor Brendan?
Which question did you want me to tackle?
The one about immunity in the communities.
What was the question about? I'll answer Glenn's first, and then come. Is that the one? Glenn's one. Yeah, oh yeah, Glenn's one. So this is a question that says, if you're successful in reducing the incidence, that's great, of course, but but because there's so much less malaria around, you create a group of people who now have no immunity to malaria because they weren't consistently exposed. Of course, the first, I do understand the premise of the question. The first and most important thing, though, is that's a win, right? That's actually what you want. But I get it. There's a caution in clearing out a pathogen. You know, during the COVID, the heady days of the pre-vaccine COVID pandemic, a lot of border closures, of course, were there, and with those border closures, there was a difference in the movement of some other diseases, flu and respiratory syncytial virus in particular, that normally move around. And so they went to zero in many countries. Certainly in Australia, flu and RSV went to zero. I imagine it did. This is seasonal flu. But in Australia that didn't have COVID either, the excess death rate was negative 5,000 for those years because there was no flu and RSV. To your question, and of course, then there was a group of people that were, in RSV case, of very young children who were susceptible to RSV when RSV came back, you know. And so the question was, the context was, well, it was bad not to have those viruses circulating because we now created a group of susceptible people and we got disease back. I didn't look at it that way at all. I looked at it completely the other way. I looked at it to say, well, how can we achieve lower levels of these viruses without something restrictive like a border closure? So look, it's of course absolutely desirable to create a whole population of susceptible people because you've cleared out the parasite. But the big word of caution, Glenn, that I know you're getting at is you can't stop there. Malaria just comes back. If you've taken your eye off the ball, it comes back and you're in big trouble, possibly bigger trouble. As some countries who have eliminated malaria in the past, Sri Lanka is a classic example, worse malaria when they took their eye off the ball. So absolutely understand the premise of your point. The job's not done, especially in the tropics, the job's not done when you've eliminated or reduced by any means at all, especially in the absence of a sort of measles-like vaccine. Of course, it's the holy grail. We want a vaccine that you give to young kids and lasts for a very long time. We don't have that yet for malaria. So it's a desirable problem to have, but it's still a problem to have, that we have.
I just wanted to go back on the principle that we actually all need to be hopeful and be encouraged by progress, and I'm a glass half full sort of person. I was, in relation to the question I was asked about working together and working in a way that fits individual countries' health systems. I think with Global Fund and Gavi, there has been progress. I was involved when I was at Gavi with an exercise where we were both funding aspects of health system strengthening, and we agreed jointly, and our boards agreed, you should do it together. It's, you shouldn't have these parallel systems. And we spent a lot of time trying to do it, but each of our organisations and our boards had requirements for reporting and processes and different reporting timeframes and different grant rounds. And in the end, we actually gave up on it because it was just too difficult. So that's when I said processes trump impact often. However, progress has been made. So I think the Global Fund and Gavi are really working together. They work together on piloting the vaccine, but they're also working together on health systems work, and I think it's making more progress this time, and hopefully we'll keep making progress.
Great. Keep making progress. That's good. I'll take 2 more questions and then we'll need to round up. Over to you, sir.
Thank you. Wonderful session. Fascinating. Thank you very much. I'll try and make my question short and intelligent, if that's okay. If my understanding is correct, yeah, it's correct. I don't know the answer. It's very difficult even to start speculating. My suspicion is that basic things, and this comes to the issue of innovation, that maybe we're looking at innovation in too narrow a tunnel. And that, we need to start embracing other issues, poverty, development, and so on. There's one thing, I'll put good money on that, if one were able to provide African rural villages with electricity, just electricity, you would go a huge way to solving the malaria problem in Africa, because it would mean that people don't have to cook outdoors. I know, people don't have much disposable income, but I'm willing to bet that a lot of people would give some money towards buying a little electric stove to cook their food indoors rather than outdoors. You can have a simple fan, which has a repellent effect on mosquitoes as well. Fans chase mosquitoes away. People would spend more time indoors and not risk being bitten outdoors. Just electricity. So, it's things like that, or cheap wall linings, mosquito mesh that will keep mosquitoes out, stuff like that. Thank you.
Great. Your question was very intelligent, but also very long. So allow me, coming from Africa, maybe to start, and then I'll hand over to my colleagues. I think you answered the question yourself. A lot of times we're looking at the malaria problem from a health perspective. But really, if we look at the countries that have been able to eliminate, 90% of the work is not from the health systems, but it's from development. How do we make sure that our gutters are clean, there are no potholes, working with the agricultural ministry, with the private sector, with education. And that's where we are getting to now, and that's the realization we've come to on the African continent, that we need to continuously engage with the other sectors. We have examples of where it has worked, where development has really been the driving force of malaria elimination. We're seeing it in Cabo Verde, which was certified this year. We're seeing it in Rwanda, which has made tremendous progress in bending the curve. We're hoping that development will actually be the catalyst to malaria elimination on the African continent. So I fully agree with you, but we just need to continue to unlock some of those opportunities in terms of development vis-a-vis malaria elimination. Professor Brendan, did you want to add?
Not much, but I'll have a go. That's very, very good answer. So when I started out in malaria research in the mid-'80s, it coincided with a Nature paper in Nature. Of course, if you're a researcher, you try and get your papers in Nature, so you look at them very closely. It was from Jeff Sachs, and soon after followed up by Amy Bateson from the World Bank and a few others, and they were turning this on its head a little bit. We've talked about shrinking the malaria map, and they were linking shrinking that map to economic development, actually, but they meant development more generally. And the thesis that Jeff put forward and Amy and others put forward later was that you actually had to get rid of your malaria first before you could develop. And that those countries to the north and south of the equator, particularly to the north of the equator, as they got rid of their malaria, they developed further. So I absolutely agree with the point that you've made, but I think there's a lesson in there that it is for heavily malaria endemic countries, it's a big challenge to get over the burden on society that comes with that. So, and in terms of difference between Africa and countries at the equator elsewhere throughout the world, it's a good it's a good question, but there are 22 of the 80-odd countries that have malaria endemic that are outside of Africa. There's also other differences, different mosquito vectors, of course. Anopheles gambiae, amazing vector, and its interplay with the Plasmodium falciparum in Africa is really quite different to the mosquito species. I mean, they're completely different. I know they're still Anopheles species, but they're completely different. They don't look anything alike. That are outside of Africa and that interact with Plasmodium falciparum that is also completely different, as well as other species to the one in Africa. So there are differences that are biological between the places. I just think that we need to come at it from both angles. The development angle, most definitely, that you've spoken about, but also saying, actually, countries with a heavy malaria burden need help to get and a focus on malaria specifically, so that other things can grow as the malaria burden goes down.
Yeah, I just to add to that, which Brendan actually has said, it's, to my mind, it's not an either or. It has to be both, and surely that's the point you made very well. Is that's what the Sustainable Development Goals are all about. That you have a whole range of factors. The Millennium Development Goals were very siloed, one might say, and then all the consultations said, no, we can't do it like that. We actually need to poverty, education, women, climate change. And I know that's a lot to ask, but that's both specifically targeted, but also across the board. And the other thing is that this region is very different to Africa in terms of its economic development. I mean, it's been growing. It's actually, this region's been the fastest growing, economically, the fastest growing area, and I think that does make a big difference.
Great, thank you. Unfortunately, we've reached the end of our session, so I won't be taking any more questions. But really just to thank the panelists for an engaging 1 hour, 20 minutes that we've had. But maybe just to summarize on the 3-4 big themes that I see coming out of this conversation. Obviously, new tools are important, but the question is, how are we maximizing the old tools we have, and how can we quickly deploy the new tools? What do we need in that aspect? Issues around community engagement, community accountability, and making sure that we're constantly not just engaging the communities, but we're also giving them feedback. So it's not a one-way stream, it's more of a two-way stream. I think part of our processes also need to change in terms of changing mindsets, changing the way our donors work, and some of the demands that they put on the countries needs to be realistic in terms of some of those aspects. I think the third thing is, what are the trade-offs we need to make, given that we don't have all the resources. We need to start thinking about that as we deploy new tools. And finally, it is really breaking down the silos. We cannot continue to look at it from a vertical perspective alone. We need to integrate, we need to collaborate, and we need to just make sure that at the end of the day, we're making the best of the little resources we have. So on that note, I really thank you for your engagement. Thank you to the panelists, and thank you to the organizers as well. Really enjoyed this conversation. Thank you.